Let's get into it. I'm going to pass it over shortly to the amazing team that we have presenting today. We have Dr. Chandra from the University of Mississippi Medical Center, joined by his colleagues Greg Hall and Brianna Petty and Bethany Smith. And then we have Teresa Harvey from Copiah County Medical Center. And the University of Mississippi Medical Center is also a center for telehealth and emerging technology. It's a center of excellence in telehealth that's designated by HRSA, and it's one of only two in the country. So we're very excited to have these folks on the call today. But I'm going to pass it over to Brianna and Bethany to kick us off, and we can stop sharing and have the team take control over their slides. Welcome.
All right. Thank you so much, Jessica. Good morning. My name is Brianna Petty. I'm one of the clinical nursing directors at the University of Mississippi Medical Center. I'm so excited to be here today to be able to tell you a little bit about what we have done with our virtual nursing program and how we've leveraged AI within that. And so Bethany and I will get into that. But before we do, Holly, if you'll change the slide. I do want to note that none of the speakers presenting today have any disclosures. And then we also would like to acknowledge that this project has been funded through HRSA and federal funding, and we are so thankful for their support in helping to make this possible and improve patient safety and outcomes in Mississippi. Here are our objectives for the day. So we do want to introduce our virtual nursing program. We want to discuss our findings of AI through that, and then discuss future challenges to implementing AI in rural healthcare environments. All right, so before we get started, I want to tell you a little bit about the University of Mississippi Medical Center. So UMMC is the state's only academic medical center, and it is located in Jackson, which is in the heart of Mississippi. Our focus is to improve the lives of Mississippians through three different missions: education, research, and healthcare. And our Jackson campus consists of an adult hospital, critical care hospital, a women's hospital, and the state's only children's hospital. We also care for Mississippians statewide through community hospitals in Grenada, Holmes, and Madison, in addition to our Center for Telehealth that offers specialized care remotely to many locations throughout the state. So as you can see from this slide, we are the second largest employer in the state of Mississippi, and we have many of the state's onlys. And so as UMMC, we continue to play a crucial role and a central role in delivering healthcare across the state of Mississippi. All right, so as we go into our program overview, I would like to start and just kind of give a general overview of where we've been and where we've gone, and then we'll move into our workflows. So over the past few years, we all know that healthcare has changed, and COVID placed a significant strain, I know, on the nursing workforce. And we were seeing how organizations began to rethink how care was delivered at the bedside. And I vividly remember the day a group of leaders came around the table at UMC to determine how we could leverage technology to better support and care for our teams. I know we had just been through COVID. In my areas alone, we had seen a huge spike in nursing turnover due to several leaving to the travel market. So we were struggling on many fronts and just saw that the nation was moving towards technology and a way to virtually help support our teams. And so that is how our virtual nursing program was born. And we're so appreciative to our Dr. Chandra and the Center for Telehealth that truly helped us bring that vision to life. So on March of 2023, we opened our virtual nursing pilot on 6 West, which is a 14-bed unit. We staffed with our virtual nurses on site. They were not remote. They were here at UMC, and they were housed in a small room that used to serve as an old telemetry monitoring space. They staffed 7 days a week and worked 9A to 9P. That was in order to help us cover a majority of our admissions and discharges. And then in February of 2025, we expanded our program to 4 North, which was a 32-bed unit. So we now collectively had 46 beds that we were monitoring under our virtual program. We introduced a new technology vendor at that time that had AI capabilities, and we also introduced virtual observation. So the focus of our virtual observation was to reduce patient falls. Patient falls is one of the leading causes of preventable harm in the inpatient setting, and we are not immune to that like many of the other hospitals in the nation. So during that time, we also were building out a new unit, and we were able to have a spot on that unit for a new virtual bunker. So we do have a new location that our staff are living in right now, and that has allowed for growth of both RNs and virtual observers. So on the next slide, I will show you a picture of what those spaces look like. So here you can see phase one on the left and then phase two on the right. Phase one shows our inpatient room camera setup. It was a separate monitor from the TV that had the camera attached at the top. And then the bottom picture shows that old telemetry space that we turned into our virtual bunker. It had just enough room to house 2 virtual nurses in there. And then on the right or the middle picture, you can see our new virtual bunker. We now have cubicles that allow for more privacy, and you can't see the entire room, but there are 5 cubicles, so that will allow for growth and expansion. And then you also see inside the patient room with our new vendor, we have the camera in the ceiling and we are integrated into the TV. And I won't go too much into technology because I do know Greg will be speaking more to that later in this PowerPoint. So right now I'm going to turn it over to Bethany and she'll give you an overview of our workflows in our program.
Thank you, Brianna. Hello, everyone. I'm Bethany. I'm the nurse manager for 6 West. I'm here at UMC, where our nursing program began and was implemented. And I also oversee the virtual inpatient team. So here our virtual nurses are very similar to other programs, but our primary focus is discharge coordination. They collaborate with patients, families, physicians, case management, discharge lounge, and bedside staff to identify barriers early and streamline throughput. Virtual nurses, they support admissions, patient education, and rounding, as you can see on the screen. I often refer to our virtual nurses as fairy godmothers, not only for patients, but our bedside staff. They're watching labs related to high-risk medications, monitoring vital signs, and reassessing pain, to ensure that they are a resource to our staff. All of our virtual nurses have to have a minimum of 5 years nursing experience to help, again, be that fairy godmother. Let's see. A notable soft win that we have seen with their involvement is in rapid response and codes, with them helping with documenting events remotely while bedside staff are providing care, and they have quick access to the EMR to answer any questions from providers. But again, our program was focused on admissions, discharges, and rounding, as Brianna mentioned. We did expand in February of 2025 to phase 2, which is when we added our virtual observers to the team. And as you can see in our next slide, a picture of our virtual observer. You see 4 screens that she's monitoring. This virtual observer, is monitoring up to 20 patients at a time. She can have 16 on each screen, but we have chosen 20 to be our safe number. We use the same approach with virtual observers as we did virtual nurses. We hired within the organization and to include them to work on site and to help guide our workflows and to establish those workflows. They are the experts on the floor giving direct care. So they're familiar with the patient workflows and how to communicate. So we built those together. They are, like I said, they are monitoring up to 20 high fall risk patients. And those patients are identified by the bedside staff each shift, just to ensure that both the virtual nurse, the bedside nurse, and the virtual observers are all on the same page. And Holly, if you could go to the next slide, I'd like you to show how our AI component is involved in our virtual observation. As you see, there's green, yellow, and red. So safe, caution, and alert. For green, the patient is laying in the bed, not anywhere close to getting up. This AI component identifies a patient with an armband, a gown, or an IV. So most has to have two of the three to identify. So if a nurse walks in the room, it identifies that is not a patient based off of that criteria. But as you see in the yellow, if the patient tries to scoot closer to the bed or have a leg out of the bed, it flags for the virtual observer to alert the patient. That virtual observer can call into the room and say, "Hey, Mr. Smith, please get back in bed," or ask if they need anyone, to try to remind them, "Let me call someone for you." Or if it's a confused patient, just remind them to getting back in bed. They can also, at that time, notify the bedside staff. We primarily use Vocera to communicate, or phone, just to help make sure that the bedside staff are aware that patient is trying to get up. If the virtual observer can call and redirect the patient, then we don't have to have bedside staff intervention. But in the instance where the patient is not redirectable, and the screen turns red, which is alert, then we can set an alarm off in the patient room. So the virtual observer will set the alarm. It is a different alarm. It's like a Belgian fire alarm. And that is different from like our bed alarms or any other alarm. The virtual observer will continue to talk to the patient, trying to redirect, to help make sure that the patient doesn't fall. Sorry, can go back. Holly, I'd like to show this graph above about the virtual observer redirections from February of 2025 to December 2025. I mean, as you can see, there were many redirections with staff intervention. So alarms is the top graph. Orange is 6 West, which is my unit, 14 beds. And then the blue is 4 North, 32 beds. So a total of 46 overall monitored. And then, but you can also see, like with redirections there on the bottom, the virtual observers are redirecting these patients, talking to them, and just either answering their question or notifying bedside staff if they need anything. But that is a huge time saved for the bedside staff, because the redirection did not require a bedside staff intervention. But overall, we have had, with any new program, new challenges, just making sure that our workflows are obtainable for the virtual observer, where we are trying to make sure that we've made it a year now, and just keeping a pulse on our virtual observers as well as our falls and our patient safety. Brianna, is there anything you'd like to add to that?
No, I don't think so, Bethany. Thank you. The only thing I guess I could mention around some of the technology, we will get some false alarms every now and then. It's not a lot. But sometimes, with technology, you may see a patient that's just shifting around in the bed and it may turn yellow. The virtual observers can reach out to that patient and they'll let them know, "Oh, I was just shifting around." So they get to know the patients pretty well. because they have a lot of back and forth communication. And then the only other thing I'll add is we did do inclusion and exclusion criteria for what patients we would monitor and would not. So we cannot monitor any suicidal patients. So it does not take the place of monitoring suicidal patients. We do have to have an in-person one-on-one observer for that. And then we had done a lot of work on truly trying to reduce our one-on-one patients. I know this has been a question in the past. Have you been able to reduce that? We had done a lot of pre-work prior to this to really try to implement strategies that did not involve one-on-one sitters. So we haven't seen a huge reduction in that because we were already doing well in that platform. Occasionally, we do still have to have somebody one-on-one just because of impulsivity or the patient is just not redirectable. And so those are cases we would still have somebody one-on-one at the bedside. But overall, I think that this program has been great for us. It has allowed a peace of mind for our staff. They know that somebody's watching their patients, but also it's given a real peace of mind to our family members as well. I think some families can feel comfortable going home knowing their loved one is being watched more closely. And so those are some soft wins we definitely have seen. So with that being said, Holly, if you want to move forward, I will let you know what our data and metrics have showed. All right, so the first slide, you're going to see 4 North. This is our falls 10 months pre and post. So looking back 10 months and then the 10 months, the first 10 months we were live. And so you can see they have reduced falls significantly on 4 North. This is the 32-bed unit. So almost 38% reduction in falls, 50% reduction in falls with harm. And that's according to ND and QI definitions. Any fall with harm, we consider that here. And so we're really excited to see the impact that this has had on 4 North. But as to move along and show you 6 West, which is our smaller unit, you will see almost a stark difference. So falls are going up on 6 West. And when we look at those results across both units, you do see 2 very different outcomes. And so it's important for me to help put some context around that. So 4 North is the larger 32-bed unit. We saw that 37% reduction in falls, 50% reduction in harm. That did have a meaningful impact. But on 6 West, the smaller 14-bed unit, we see a 133% increase in total falls. They went from 6 to 14 in the 10 months prior and 10 months post. However, I do want to point out that the falls with harm remained unchanged. And so that does show us that while falls increased, the severity did not worsen, which I think is a key safety consideration. And there's a few key factors that likely explain this. The first difference is 6 West had an exceptionally strong prior year going into implementing this. They only had 6 falls total in that year prior. And so when you compare that, to this current time frame, as well as the small unit, it can look significantly higher. When we go back and look at the historical performance of 6 West, or when we compare 6 West to our other like smaller units, it is very neutral, if not slightly better this year compared to last. So I think there were a couple of factors that played into that. And while we do show that this model shows more success in the larger unit, like 4 North, than 6 West, we can interpret that with consideration to that baseline performance, the unit size, and just variability. So we go on to the next slide. I want to tell you a little bit about our employee satisfaction. And today for this call, we are focusing more on our virtual observers and our AI technology and what we're seeing around that. but certainly we have a lot of data that shows satisfaction around what our virtual nursing components are doing. Today, I really want to focus on virtual observation. And so, as you can see, in addition to reducing our patient falls, we also look closely at staff experience. So we did a pre 3 months and 6 month post survey. And I want to point out specifically the results around hourly nurse rounding and then their ability to deliver safe, high quality care. So we asked these two key questions, and as on the screen, you can see the results. And so with how satisfied you are with the hourly nurse rounding, you see that increase significantly from 34% up to 92%. And then in how would you rate the quality of care and patient safety you are currently able to provide? We saw that jump from 79% up to 92%. So that's significant, and it does show from a safety standpoint what our nursing staff thinks. So we're really excited to see that. So you can move on to the impact we're having on employee engagement. I wanted to show this because we're really proud of this. This is 6 West. This is our unit that has had virtual nursing in addition to virtual observation the longest. And when we look at their employee engagement, the impact is compelling. We are a large hospital, as I mentioned earlier, and 6 West achieved the highest overall employee engagement score across all inpatient units in our adult hospital. That's over 25 units. That's critical care, women's services, ED, all inpatient units. And if you're familiar with how the inpatient setting works, you usually know that you don't have as much engagement necessarily in med-surg and acute care as you do in some other specialty areas. This unit outperformed all of them in employee engagement. And so I think that speaks volumes not only to their leadership, but also to this program and what it has done for the nurses on that unit. In addition, I don't have this on a slide, but we have also seen this reflected in retention. 6 West has had zero RN turnover for the first 18 months that we had this program, which is an exceptional accomplishment in today's environment. And then on 4 North, we have also seen an 18% reduction in RN turnover over the past year. They have only had this program since February. And so looking at these things together, I think these results strongly suggest virtual nursing and virtual observation are not just supporting our patient care, but they're also creating a more sustainable work environment for our nurses. All right, so looking ahead, there's a couple of things on the horizon for us. We do have a deterioration index model that we are about to put into place. And this model helps us detect early, this model is a predictive model if you're not familiar with what the deterioration index is. And it uses real-time patient data, so vital signs, labs, clinical indicators to identify patients at risk for clinical decline before that may become apparent to the frontline staff. And our model, we're going to allow our virtual nurses to intervene early on to potentially help prevent early deterioration. So that is on the horizon. And then we are also exploring the use of AI to support pressure injury prevention. And how that works is the program will help identify those high-risk patients based off of our documentation. And then the AI will help us in prompting a countdown clock or setting a timer according to what position the patient is in to help maintain that timely repositioning and care interventions that go along with that. So together, those steps help us build on the foundation that we already have using technology to enhance our clinical judgment, improve early detection, and ultimately help us continue to deliver safe care. Right, so now I will turn it over to Greg to talk about technology.
Hello, everyone. I'm Greg Hall. I'm the Director of IT for the Center for Telehealth at UMC. Holly, next slide, please. So just to give you a 30,000 foot overview of what the technology looks like. So we're using a couple of different technologies. So first being the video camera, that is the centerpiece for all this AI technology. But in addition, we are using ultraband equipment and then voice recognition through in-room microphones. That's handed off to the middle piece, so the data center piece, that then results in different programs being able to be utilized by the different clinicians across the campus. Of course, we're talking about remote nursing and telesitter today, but it can do other other systems such as hand washing, making sure that the staff are washing their hands for the inner rooms. It can be used for OR coordination and then also for telehealth visits. But to be very fair, what we're using it for today, it is exclusive for telenursing and telesitting. Next slide, Holly. So just to give you a little bit more idea of what's actually in the room, the main system in the room is a system on a chip. So that's what the little middle board is in the middle. It's connected to the camera and the microphone in the room. There is compute on the system itself. So a lot of the algorithms that we're running, like fall prevention and then the next step, pressure ulcer detection, actually happens on the system in the room, so that you don't have to have a ton of video data being fed to the data center when it doesn't make sense. Some of the other usage, such as the OR coordination, does require that camera feed to be fed into the data center, but the vendor is very good about being able to separate those two technologies out. So when you don't need to move that huge amount of traffic across your network, you don't have to. But as Brianna referred to earlier, very crucial that this system is connected to the patient in-room patient display. Brianna kind of hinted at the older solution. It was a standalone solution. There was a lot of hiccups with that solution because of the patient room display. Patients would have the volume up really loud, and then all of a sudden the virtual nursing and virtual telesitters couldn't hear what was going on in the room. So we made up for that mistake in the second go around and made sure to use the patient display so that we don't run into those barriers. Next slide, Holly. As far as data integration, this is a very loose system as far as data integration back into the electronic medical record. It's actually something that we're working with the vendor on now. But to be very frank, the only data sharing that's happening between our EMR and our AI video solution is two things. So the patient name and the fall risk score. Some of that will start being changed when we start working more closely to get pressure ulcer detection working. There will be more voice commands that happen that then relay the information back into the EMR. But we are working very closely with the vendor in order to make sure that the nursing staff and the clinical staff can stay within the EMR. But to be very frank, today, most of the work occurs in the vendor solution, and then a lot of the documentation happens in the EMR, but some documentation still does occur in the vendor solution. Next slide, Holly. And I think that hands over to Teresa.
Holly, would you mind advancing my slide?
Teresa, before you start your presentation, can I interrupt for a second?
Sure.
Okay, so for the audience, this is Saurabh Chandra. I'm the Chief Telehealth Officer here at UMC. For the audience, I wanted to, clarify what we are doing, introducing Copiah, the pilot at Copiah County Medical Center. So what we're trying to show you here is two things. One, what we have already shown is the implementation of this pilot at our academic medical center, which is a safety net hospital, the only academic medical center in the state. So we have shown the pilot, we have shown you the results of that. But then we also simultaneously wanted to try this implementation at a rural hospital, a critical access hospital, to see, what are the challenges? Does the algorithm perform as well does we get the same kind of results? And Teresa, who's the chief nursing officer, and her team members have been really helpful in trying out this pilot at their hospital. So what you're going to now listen is the story from Teresa on how the implementation went when we tried this out at the Copiah Medical Center. So over to you now, Teresa. Sorry for the interruption.
No problem. When we formed the relationship with UMMC and took part in this pilot, we went ahead and included the same technology in our ED and med-surg, so that was a total number of 33 beds. We implemented the vendor AI dashboard with the visual fall risk alerts at the nurses' stations and telecritical care. That was phase one. Phase two was to move on to pressure ulcers and hand hygiene. Next slide. Our structure was the same as UMC, with one exception. We had cameras and sensors in the patient rooms on all 33 beds. We had monitors. Our monitors were at the nurses' stations. We did not have the resources to have separate virtual observers or nurses monitoring the patients. Our monitoring was performed by the nursing staff and the unit secretary. The challenges that this caused was that we did not have 24/7 nurse actually watching the patients all the time. This was left to nurses that were at the station that would be able to look at different times. The unit secretary, who is always at the station but has other duties. So that made our validation harder. We were unable to validate as quickly for reasons that because we didn't have someone just there looking at it all the time, it was harder for us to validate if the software was working, when it was working, to identify the challenge, identify what was not working. So that put us at a disadvantage. One thing that our nurses, we also did the surveys 3 months before and then afterwards. One thing that we noticed is that our nurses felt like, even though they noted in the survey that they liked the ability to be able to see in the patient's rooms, they did feel like it increased their workload because, or it did, they were kind of not as high, they did not feel as strongly about it increasing their workload, but none of them felt like it had decreased their workload at all. So that was a concern. They felt like monitoring increased the workload. It wasn't consistent, and they didn't really feel like that it helped them in their overall care of the patient. Next slide. Oh, I think that's all my slides. So that was it for us. One thing that I would tell rural health facilities is to make sure that if you're planning to put these programs into place, is to make sure that you have a plan to be able to offer the virtual observers and the monitoring. That's key to this, the success of this program. That's something that we're exploring now to see how we can implement that in the future. Our nurses do like it because they can monitor a patient from the desk, they can check on them, but they have not been able to experience the full benefits of the program like the nurses at UMMC. Thank you.
Thank you, Teresa. This is Saurabh Chandra. Holly, you can stick with this slide. I don't need for you to move any more slides for me. I think Teresa, stated very well the challenges that were experienced by Copiah Medical Center. And I just wanted to start by telling a little bit about ourselves. We are, one of the only 2 national centers of excellence for telehealth designated by HRSA, a federal agency, which allows us to receive funding and that allows us to innovate in the field of telehealth. And we are tasked with coming up, implementing projects and evaluating them, and then providing evidence-based best practices for implementation. So the first question is, why did we choose to set up a nursing, a virtual nursing program? And as everyone knows, especially during the COVID pandemic, there was severe shortage of nurses, and that was exacerbated by the increase in burnout and increase in the feeling of having more workload experienced by the nurses. And although the situation has stabilized somewhat since the pandemic has abated, it is still real. There has been a very large national survey of almost 800,000 nurses that was conducted by NCSBN in 2024 that showed that although the shortage has stabilized somewhat, almost 138,000 nurses have left the workforce since 2022. Replacing them is not going to be an easy task. And out of the remaining nurses, 39% of RN and 41% of LPNs are considering leaving the workforce in the next 5 years. And out of the survey, one of the biggest things that came out of that, the nurses who are considering leaving the workforce in the next 5 years, almost 40% of them state that the primary reason for them is the increase in workload, burnout, and not having the good work-life balance. So when we started this project a couple of years ago, and that was to answer a couple of questions. One is, can virtual nursing program benefit the bedside nurses, offload them, and give them back some time to either for themselves to have a better work-life balance or take care of the patients? And you have seen that data that very well speaks for itself, that there's higher engagement in the units that have this virtual nursing program, higher satisfaction with the program, with a lot of tasks that are undertaken by our virtual nurses. And once we were able to demonstrate those results, then we said, well, we have gone this far. Now what should we do? Can we bring on the AI technology to take it even further? And as you have seen, that we have great results with fall prevention. Now, the biggest thing is, and the biggest challenge, one of the biggest challenges, well, great study, great work that has been done as a pilot, but what should we do to sustain it and scale it to the entire medical center? That's the number one thing. And those of you who are thinking about, along the lines of implementing AI technology or a virtual program, I wanted to emphasize that having good baseline data to compare is really, really going to be helpful when you have to answer the question to your C-suite: is program yielding results that are good enough for that to be sustained, scaled, or for the investment to be put in from the hospital or the enterprise? And it's a challenge with the virtual nursing program because of many reasons, and I'm just going to allude a few of them. One is there's a lot of virtual nursing support and staffing that you require to support this program, and we had virtual nurses, and on top of that we had virtual observers. And although our virtual observers were not nurses, and that reduced the cost, but still it is the staffing component is still the primary driver of the cost. And when you look at the fall prevention, you're looking at kind of cost avoidance from penalties or increase in length of stay. So those are some of the things that you have to work with your financial team to ascertain beforehand, and make sure that you have the data that after the pilot is done to convince that this can be sustained and scaled at the enterprise level. The second thing is that, and most of you are probably aware of the Rural Health Transformation Plan, where, 58 states have gotten received funding from the federal government to implement innovative programs that would help and benefit the rural population. And many of the states, and actually almost all of the states, are looking into how they can mitigate workforce shortages that are existing in almost every state. And virtual nursing program is one of them. So when the big lesson that has come out of this is that what can be done at an academic medical center with more resources, how can you then replicate in smaller rural hospitals? And Teresa has laid out very well some of the challenges that they experience. They are resource limited, and their ability to hire and staff 24/7 nurses or virtual observers to do the same thing as we have done at our medical center is not always possible. And you may have heard her say that their nurses felt that their workload was not minimized. Actually, they felt that it may have increased. So one of the big lessons for those who are thinking about implementing in smaller hospital, rural hospitals, is that look at the technology that does not require so many resources. And the field of AI is moving rapidly. Now, there are vendors out there that do not require virtual observers, and that looking into what best technology is going to serve the purpose is really, really important. Also, a model where a centralized hub, like for example, in our academic medical center, that can support a network of other smaller rural hospitals, and you have a hub so that a centralized nursing or virtual observer station can then support other rural hospitals, is probably the best, way to provide those kind of support to a smaller hospital. So with that, I think I'm going to end it here and hand it over to Holly to wrap it up, and happy to take any questions.
All right. Any questions? I have a couple that I noted from the chat. Wondered if you wanted to come off of mute and ask your question. Otherwise, I'm happy to do that on your behalf. Okay. I will go ahead and kick us off with the first question that hasn't been answered. What does consent look like for the patient that's being observed?
Hi, this is Teresa. I can answer that. In our general consent to treat, we did add video monitoring in the general consent. However, we also inform them at admission. There's also signs in the room. If a patient desires to opt out of the video monitoring, we have a release that they sign, that they understand they will not be monitored by video. There are no HIPAA issues because we are not recording. It is real time monitoring, so there's nothing recorded. We have had 2 patients at Copiah County that opted out of the monitoring, and both of them had falls. So, have not experienced a lot of people opting out, but they do have, they do have that option if they want.
And I will say, from the UMC standpoint, it's the same as Teresa said. It is covered under our general consent to treat. And we also do not record. We have signage in the room. We do not have anything that they have to sign in order to opt out, but they do have that option. We do rarely see that, though. Most patients and visitors, once we explain to them that our virtual observers and our virtual nurses are part of our care team. They are just here virtually. Most patients have been very accepting of that, and so we've not seen a lot of opting out.
Thank you both for that. Just double check if there are any new questions here. I think that one has been answered. Anu, would you like to ask your question?
Yes. Hi, thank you. First of all, this is so amazing. I'm so glad you're all doing such an amazing job. I know how difficult it is to actually monitor all these patients. So with that said, I mean, the two patients you said fell because they didn't have the monitoring. I mean, would that happen without the virtual monitoring otherwise? And with that experience, would you be able to inform your patients that if they opt out, I mean, there is a higher risk of falling? Would that be a good way to help them make an informed decision? I just wanted to know if that helps them and helps you as well, because at the end of the day, it's the outcome that matters, right? You want your patients to be safe, regardless of how you monitor them. I don't know. I don't know if it was a lot. So thank you.
Brittany, you want, Brianna, you want to take that? Or
I will take that one. I know
Yeah.
Teresa mentioned her two patients that have fallen, but we certainly have also had patients that have fallen while they're being virtually observed, or patients that maybe didn't qualify as a high fall risk, that were a moderate or a low risk, that weren't being monitored. They fail, and then we put the virtual monitoring on them. But certainly, it is a talking point for patients on why we're using this technology, and that it is for their safety. And Teresa May can speak to her two specific patients, but I will say some patients are receptive to that and listen, and other patients, unfortunately, they're set in their ways on what they would like. And so sometimes it works to re-educate the patient and really explain what we're trying to do and the benefits of this program, and sometimes it does not. But certainly we would definitely try that. Teresa, do you want to add?
Yes, the two patients that we had, it's ironic. One of those was a nurse that worked in our med-surg unit that opted out. She opted back in once she fell and had an injury. The reason we get them to sign something to opt out is it gives us some talking points of what it means when you opt out, and has the patient understand the risk involved. So that kind of covers us from a liability standpoint, and also gives us the ability to inform them of what risks they're taking by not being virtually monitored. And that has worked well. We usually it doesn't come up. I mean, it's in the consent, and then we have signs in the room, and we don't have, we have very minimal questions from patients regarding the monitoring.
Thanks, Teresa and Brianna. Jacqueline, I seen your hand up.
Hi, my name is Jacelyn Blankenship, and my question has to do with nursing education. Are there programs or plans to begin integrating virtual nursing practices, philosophies in formal nursing education programs? And then the second question, or maybe second part, is do you feel that if all nurses coming into your facility receive orientation or some sort of contact with the virtual nursing and virtual observers, that they would be more supportive and kind of facilitate helping patients throughout the medical center feel more comfortable about the value and abilities or the value and the preventative care that these individuals receive.
So I will take that one, and then if anybody has anything to add, they can jump in. I am unsure if any of our nursing curriculums around the state have started to include virtual nursing. I have not personally seen that, but I am unsure of the answer. So if anybody has any insight into that, please feel free to speak up. I think that is a great idea. And I think as we see that continue to grow, we will see it integrated into that. I know that our clinicals, our students that come in, they are getting to see it firsthand and to experience it. But being taught in the classroom, I'm unsure of that. To speak to your second question about introducing all of our nurses as they come in to virtual nursing, we have not expanded it to a house-wide education. We have done several forums where we have presented what we are doing. So I know that there are a lot of people that are aware. And we do general orientation for our nurses that are on our unit or that generally float to the unit. If we have somebody that comes that day that has never worked on the unit, the charge nurse or the educator usually give them a good orientation to how that works. But yes, our frontline staff are promoters of virtual nursing and virtual observers. They are all very happy with the program and what we're doing. So they certainly promote that. And we have several units that are really excited and wanting it to expand to their areas. So we know that word is spreading. And when we moved from 6 West to 4 North, when we expanded, we did utilize the 6 West staff to help the 4 North staff get on board and truly understand. Because what we realized, until you implement it and the nurse actually gets to see it, it's really a hard concept to understand until you see it actually work. So you're right, they are the best promoters of it, the ones that have actually been there and doing it, and they do help us spread that message. So thank you for your question.
And this is Saurabh. I'm just going to take Alifia's question there, like how did the model behave? And for most part, the model behaved and as well as it was expected and along similar lines from what we saw in the academic center. But there is a very interesting story that I wanted to point out, that for a long time, for a period of time, the model was actually not working at Copiah Medical Center. And then what we figured out, what the team and the AI team figured out, that the model was trained to identify the patient and differentiate it from the bed based on the color of the gown and the color of the bed sheet. And for most parts, the bed sheets are white and the color of the patient's gown is of different color. But at Copiah, they were both white. So for when they started testing and validating the model, it was not picking up, it was not even identifying the patient. And it took them a time, and that's the real bias there. It took them the time to really figure it out. Wow, that is the color of the gown. The patient is not even being identified. And they had to change the color of the gown for the patient at Copiah before the actually model started working. So that is something that we talk about in theory. We saw that in practice.
Thank you, Dr. Chandra. I'm going to wrap us up here, or pass it over to Wes in a second, but wrap us up as far as this presentation and panel and Q&A. Thank you so much to the UMMC team and Copiah Health team for your presentation today and going deeply into some of the wins, but also some of the challenges with translating this from the academic medical center space to small rural hospitals. Thank you so much for sharing your time and expertise and experience with us today. Over to you, Wes, to close this out.
Great, thank you. And on behalf of the team, I'll go ahead and share their contact information. I know Holly had asked if we could do this for them. So feel free to scan their QR code, visit telehealthcoe.org to learn more about the Telehealth Centers of Excellence. If I can ask Holly to also drop that into the chat, that'd be helpful. And for the folks still on, we'd love for you to share your feedback about this session. I did drop the link, the survey link in the chat. And to also join us on these AI in Action webinars with our community partners, as Jessica noted at the top. We do this on a monthly basis. Our next one is a crossover with High Tech with their particular learning series. So be sure to register. Thank you, Holly, for dropping that. Subscribe to their newsletter at the Telehealth Centers of Excellence to learn more. Visit their website and get more details. Thank you again to the UMMC team and Copiah Medical Center team. And for all of you joining today, we'll see you at the next one. Take care.